So my name is Carmen Abel. I am the president of the board of directors of the Crisis Workers Society of Ontario, affectionately known as the CWSO. And I would like to welcome everyone today to our third workshop that we're hosting virtually on behalf of the CWSO. So our presentation today is Older Adults in Crisis, and our presenters are psychogeriatric resource consultants. So we've got Sharon Strapp and Terry Adlam. Did I say that right, Terry?
You did, yes. And it's Sharon
Excellent.
Stapp.
Great. Oh, Stapp. Sorry, I put an
Stapp.
R in there. Sorry, Sharon.
No problem.
So the Psychogeriatric Resource Consultation Program of Waterloo Wellington is comprised of an interdisciplinary team of health professionals known as Psychogeriatric Resource Consultants, or PRCs, who provide clinical consultation and coaching on how to put principles of evidence-based dementia and geriatric mental health care into practice. They have extensive experience working with staff in long-term care homes, hospitals, community services, and home and community care. So welcome to both Terry and Sharon, and I'll turn it over to you.
Well, thank you so much, Carmen. I think that what we'll do is we'll jump right in, and I just want to welcome everybody. I believe that there's a variety of participants from different areas across Ontario, so that's wonderful. When we generally refer to crisis workers, I know that might look a little bit different in different communities. But our goal today is really to hopefully provide you with some information and some additional resources that just might help support your role as crisis workers in Ontario. When you're specifically asked to be involved, or your role is called for in working with the older adult with cognitive impairment, or potentially a diagnosis of dementia, any other major mental health diagnosis, but again, the older adults. So that's what our focus is going to be on today. And I'm going to get Sharon to pull up our presentation. Maybe in the chat, I'll just get everybody to indicate if they were provided with, one would be a tip sheet that we developed, which hopefully you'll be able to follow along with today. And then the other will be a delirium detection questionnaire. So if you want to if anyone didn't receive those, just note that in the chat, and then we can maybe share them in the chat as I'm moving along here. Okay, so again, welcome everyone. Okay, so I'll get Sharon to do that sharing while I chat. Okay. Thanks, Sharon. So as I said, the focus today is on older adults in crisis with cognitive impairment specifically and responsive behaviors. So the focus today is going to be on assessment of those responsive behaviors and understanding them. We'll try really hard to make it relevant to your specific role as a crisis worker, and we're open to any questions, comments, feedback, and we're pretty flexible today, and we'll carry on.
And I will,
Okay.
I'm just looking, I'm more familiar with Zoom, so I'm just looking and I'm figuring out how to attach. So I do have those two resources, and throughout them, when Terry's talking, I'll figure out how to send them out.
You can add them to the chat.
Yeah, you would think so. That's what I'm working on. You keep on talking. Okay.
Okay, we'll just move. Okay, so the objective today, again, as I said, is just to develop a basic understanding of responsive behaviors. And the other thing we want to do is explore what we call the PIECES 3-question framework. This framework's used to support the assessment of responsive behaviors in the older adult. It includes screening for the presence of delirium as an example versus dementia, psychosis, and suicidality, to name a few. And what we want to do is to consider how to apply this information when you're specifically working with an older adult who has a cognitive impairment with responsive behavior. So those are the objectives of today. So what are responsive behaviors? You might hear things like behavioral expressions or expressive behavior, but in keeping with consistent with the language across the geriatric system, we're going to talk about them as responsive behaviors. So we know dementia can have an effect on how a person behaves. Responsive behaviors and reactive behaviors are terms that are commonly used to refer to things like actions, um, words, gestures, all presented by a person with dementia. And we like to help people understand that it's a way of responding to something in the person's environment that might be negative, frustrating, confusing, and usually in their social or their physical environment. So some common examples of these responsive behaviors include things like verbal and physical behavior, or verbal and physical expressions, agitation, things like wandering or seeking exit, wanting to leave, restless behavior. We may see things like hallucinations and a paranoia, or even becoming more withdrawn, or might see apathy. Those are just some examples of responsive behaviors in the context of a diagnosis of dementia. I'll just quickly say, too, when I say dementia, I'm talking about that umbrella term of symptoms. Underneath that umbrella term, there are many different types of dementia. The most commonly and well known is Alzheimer's disease, but we're just globally referring to dementia despite what the specific diagnosis is for today. So keeping in mind, and this is something that we talk about all the time in our work, is understanding that there's always a meaning behind the behavior. There's always a reason or a meaning, particularly to the person behind the behavior. If any of you have any interest or any further interest in understanding a little bit more about dementia and the older adult and responsive behaviors, please take a moment to go to the Brain Exchange. You'll see that at the bottom of the slide, brainexchange.ca, under the Behavior Supports Ontario sub area on the website. And there's a lot of great information there if you have any further interest in learning more. So the PIECES framework, I referred to that earlier as one of our objectives. So the PIECES framework is used to support, again, the assessment of responsive behaviors in the older adult. And how the framework is broken down is into 3 specific questions. We're not going to go into a lot of detail, but what we're going to do is use this framework and walk through the tip sheet that I referenced, that hopefully all of you are getting a hold of now, because we built that kind of tip sheet for you using the framework. So again, PIECES supports 3 specific questions. The first one is really critical, and that is, what is the priority behavior of concern? Because we know when we're interacting with a person with dementia, there could be a multitude of different behaviors, and it's sometimes difficult to tease out, well, what's the problem behavior or the priority behavior, or what's the reason why I'm even here in my role as a crisis worker? So what's the priority behavior of concern? And PIECES really focuses on describing the behavior well. So what does it look like? Where does it happen? When does it happen? With whom does it happen? Is it a change for the person? That's the key question. Is this a change? Is it a new change? Is it getting worse, different? Are there time frames? So we really promote trying to really understand more deeply what the priority behavior of concern is, and to try to zero in on it and focus on that. Then what PIECES does as a framework is we move on to the second question, and that's focusing on, have the risks and possible contributing factors to the priority behavior being considered. And what PIECES does is we use the acronym at this point to look at that. So the PIECES. Consider physical causes, intellectual causes, emotional, a person's capabilities as contributing factor, their environment, and then even the social environment as well as the physical environment. And then any other kind of spiritual or cultural factors that might be influencing the specific priority behavior. And then question 3 in the framework helps us understand, what do we do next? And again, this is just a broad overview of the framework in its entirety, and we're going to kind of break it down and work to understand how it might be helpful for you in your role as essentially an addendum to the things that you already do, if it's, would be useful or indicated depending on the specific situation. So what Pieces does, again, with those next steps is help us understand what else needs to be done. So further investigations, potentially, even identifying interactions or communication strategies. So how to interact with this specific person with dementia. And then identifying interventions or very specific care strategies that might be the next steps. Okay. So this tip sheet, so I think everybody probably has it now.
No, I've not
no?
been successful in
Oh, okay.
figuring out how to attach it, Terry. So I will just pull it up as you're talking about it, and then we'll make sure we'll get it out to everybody after, through maybe Carmen, but we'll make sure we'll get it out to everybody after.
Let me see what I can do here.
Carmen, do you have any ways to, because normally you can just attach an attachment in the chat box, but
I think it may be only the person that's created the meeting. So what we could do is send it there.
Yeah, if you want to send it to me, I can try and I'll put my address in the chat box. And
that would be lovely. Let's try that.
And if not, I can download the attendance and then email it to everyone.
Okay.
Yeah, no worries. Okay. We'll get it to you, and we're going to stretch it out anyway.
So
okay, so thanks, Sharon.
So let me just change to sharing the other one.
Sounds good. So the tip sheet that we're hopefully getting to you is really about assessing the older adults with cognitive impairment, and it's a behavior tip sheet for you. So we know that people with cognitive impairment can have other subsequent diagnoses. So there might be underlying mental health issues, some addictions. It could be a specific type of dementia. Any other neurological condition can contribute to the development or escalation of a responsive behavior. Again, these behaviors can obviously be a major source of distress for not only the person, but the caregiver as well, or anyone else that's involved in supporting the person with dementia. So we call behavior responsive because it's not unpredictable or meaningless aggression or agitation, but typically it's due to circumstances related to the person's condition or situation in his or her environment. So Sharon is sharing that with us now. I don't know how big that is, Sharon, for people.
Well, and I can make it bigger for sure, but I wanted just to give the sense that it's a 2-page sheet. So it's just the front page, which goes into question 1, question 2, and then the details are on the back with question 3 on the back. So I just wanted to give an overview for now, and then I'll wait for Carmen to send me get this out to you. So hopefully you can follow along with it.
Yeah, so the way it's designed is you see there's little boxes besides, so it's a way for you to tick things off once you've understood kind of what's going on. The next section is a probability tool that we promote using, again, specific to the older adult and the risks that are typically identified with older adults with any kind of cognitive impairment or dementia or any other neurological disorder. And then the next section helps us understand the typical contributing factors or causes to responsive behavior, so we can sort of think about those. In your role, particularly, you're not doing like this big pieces framework or problem-solving tool, but it's a way just to tick things off and think about different things that might be contributing to the situation. And then planning a next step. So that's kind of what the tip sheet looks like. And we're going to flesh it out a little bit more deeply with a case study that hopefully is more relevant to all of you.
That's good.
Okay. So we'll just go back to the presentation when you have a minute.
Yep.
Okay. Alrighty, so the first part of the tip sheet focuses in on the priority behavior of concern, as I mentioned earlier. So this is kind of like the reason why you're there. So why was your service activated? Why was it triggered? What were the reasons why you were asked to attend? So what we've tried to do is operationalize or document so that you understand what the consistent language is actually used when thinking about these priority behaviors of concern specific to, again, the older adult with cognitive impairment. So these are most of the high risk behaviors, again, which would be typical of why you would be asked to attend to a situation. What we're hoping is it will help you describe the behavior objectively. So what does it look like? When does it happen again? With whom? Every day? When did it start? When did it change? A couple of examples would be things like verbal expressions of risk to self or others. So this might be escalating verbal behavior such as insults to caregivers, screaming, swearing, some threatening behavior that's worsening. So that would be a verbal expression of risk. And then a physical expression of risk, again, to self or others, could include how the person is currently reacting to, just say, for example, the caregiver trying to support them with personal care. So there might be pushing or choking or biting or hitting. So this helps us objectively describe the physical expression of risk depending on the context of the situation. So that's where we're fleshing out the priority behavior of concern. So then what pieces promotes or what we want to support you to think about next is that next question. So what are the risks in this situation then and the possible contributing factors? So we'll just move to the next slide, Sharon. So pieces, again, we use the RISK acronym, RISKS, to flesh out what some of the more common risks and contributing factors are, again, specific to the older adult with cognitive impairment. So this includes things like roaming, searching, seeking exit. Formerly, you would probably know this as wandering. And then imminent harm. So this could be caused by things like frailty or significant frailty, falling or falls, high risk of falls, repeated falls, things like access to firearms, someone that's living remotely that has access to firearms, and then fire safety risk. Suicidal ideation, of course, and then kinship relationships. So risk of harm, we describe this as risk of harm by the person or to the person by others. And then substance use. S is for substance use, things like assessing self-neglect, unsafe driving, and then security, like things like risks to a person's finances, housing, or access to food would be described under the S, last S. So how do we look at this when we're thinking about risks to the older person? And all of you have, you have very specific tools that you use to assess risk. This is really focused again on that older adult with some of those risks I described. And we use what we call a probability tool. So it helps us, once we've operationalized the priority behavior of concern, we flesh that out, we understand it, we can try to determine what the level of risk is using the probability tool. So for example, we might understand that a behavior has high impact in the moment, but the probability of harm is low. And that's where things like how the person is supported comes into play. So for example, if somebody's found out in the community really in distress, really confused, you've been asked to come to the situation to assess what's happening. finally you're between yourself and maybe if you've accompanied the police, you understand that the person has an address, you've been able to locate the caregiver, they didn't know they were gone, so you've been able to return them back to their home environment. And of course, there's a high impact in the situation potentially, but the probability of harm is low because you know that there's a supportive caregiver at home. They put some safety precautions in place for the remainder of, say, the evening or the night. The person's relatively safe. So you know that there's high impact, but a lower probability of harm at the moment. So it's not imminent, but certainly needs to be understood and addressed. So this is what would inform sort of those next steps. Like, who do I let know what's gone on here so that this can be further assessed and addressed? But in the moment, the person's relatively safe. So it's certainly potential high impact, but in the moment, the probability of harm is lower. Where it would become a bit different is if you learn that the person lives on their own, as an example, and there isn't anyone there to ensure the person's safety for the remainder of the evening, makes it a lot more high risk. So that's just kind of a general example of how to use the tool. Again, the hope is that you're able to potentially use this just to augment already the things that you already do. And a way to communicate too, because we've had feedback from some of the crisis workers that work in our area in Waterloo Wellington that sometimes it's difficult to communicate to the rest of the team. So that might include police or staff in the emergency department, the reason why the situation is imminent risk, because it's not always the obvious, which is, homicidal, suicidal, but that doesn't mean that the situation isn't equally as high risk or dangerous for the person. Okay. So we talk again in question 2 about, so what are the contributing factors to understanding this priority behavior? I'm going to focus in more specifically on the P and most specifically on delirium. We've had feedback that particularly when somebody has a dementia, it's difficult to tease out if there's an acute change to their baseline cognition. So we've been asked to flesh out a little bit more deeply how to understand delirium and offer some suggestions on some additional tools that you can use if you suspect delirium. So I'm going to focus specifically on the D. There are 5 Ds. When we're thinking about the physical causes, these also include things like disease, drugs, discomfort, and disability. But we'll talk more specifically about delirium using a case study that hopefully will be fairly applicable to you in your role. Okay, so the case study. So there's been a request for crisis service. Again, this will be different in various regions in Ontario. But there's been a request for crisis service. A caregiver's called because her husband, George, he's 82, he has a diagnosis of dementia, and he's trying to leave the house. He's becoming increasingly more agitated. He has been very verbally escalated. He's yelling at her, he's threatening, and he's been physically responsive. So he's pushing at her when she's trying to block the doors. So she's called 911. Police service, and you've been asked in your role as a crisis worker to accompany and assess the situation. Okay, so that's our case study. So what is delirium? So we know that delirium is different from dementia in that dementia is sort of can be described as chronic confusion, whereas delirium is a sudden change that causes acute confusion and uncharacteristic behavior. So a very specific change in behavior for the person, despite whatever their baseline is. And in this case, we're talking about older adults with a baseline of dementia. So there's already confusion there. So it can be difficult to detect for sure. Okay. And it's a medical emergency. I think Sharon's waiting for me to talk about. It really is. It's a medical emergency. And what we say to people in a role where they're trying to figure out, is this possibly what's going on? You can never be too cautious because it is a medical emergency, and it can be prevented. It can certainly be reversed as long as it's caught early. Okay. So what's it look like? Well, the person that's delirious will have significant difficulty paying attention. Again, even despite somebody with a diagnosis of dementia, if there's no superimposed delirium, the person with dementia will attempt to attend and pay attention. So that's a difference. Being very distracted, unable to follow any kind of conversation, being less aware of where they are, what time it is, so acutely disoriented, suddenly not being able to do something well as normal. So, for example, we see significant changes in ability to walk, or even the action of eating could change from normal. Saying or doing things that don't make sense, and then you may see an acute onset of hallucinations and delusions and paranoia. Okay. Different types of delirium. It's important to know that there's definitely different types of delirium, and neither one is more or less risky than the other. They're both really concerning. So I'll start with the hypoactive delirium. This one is sometimes a little bit more tricky to detect, particularly if there is moderate to severe dementia, because the person is more withdrawn and quiet, and they're not causing too much of a disturbance for others. So what you'll see with the hypoactive delirium is disorientation and reduced attention, as with hyperactive, but the person's more lethargic. The response to questioning is very slow. There's little spontaneous movement, reduced or very slowed mobility, reduced initiation or engagement, and reduced appetite. So the person seems just more apathetic and withdrawn. The hyperactive delirium, where that's different, is you see a significant increase in restless behavior. The person might be much more repetitive in conversation and activity, very agitated, hypervigilant. You may see new or acute onset of hallucinations, delusions, as I mentioned, a lack of cooperation, or you might hear this as resistant to care or resistant. Sleep disturbances, again, that are abrupt and acute. And the person might come off as really anxious and worried and fearful, like truly fearful of what's going on, which again is abnormal, typically with dementia. And then you could see some mix of both, but we won't go into too much detail about that. So what causes delirium? It can be a mix of factors. But some of the more common ones, of course, are underlying infection. So things like a urinary tract infection, bladder infection, or lung infection, like pneumonia, that's gone undetected. Recent surgery, so complications from recent surgery, and other various medical conditions, like things like cancer, things like that. Untreated pain can be a cause. Starting or increasing the dose of some medications, again, depending on the person's medical status. So again, with age comes other possible chronic medical conditions. Plus, then you add a dementia diagnosis, and starting or increasing new medication will be much more difficult for that person. You could see that trigger delirium. Things like stopping alcohol, particularly if they were heavily drinking, not getting enough sleep, and not consistently using things like hearing aids and glasses for the senses. That can be a contributing factor. It's much more common in the older adult. I think it's 4 to 5 times more common as well in the older adult with a diagnosis of dementia. Okay, so who becomes delirious? Well, it depends on, again, predisposing factors and vulnerability and what the precipitating event is. So, for example, if all of us, for example, were healthy, fit, without chronic conditions, we're really low vulnerability for delirium. So let's say, for example, someone that's healthy, fit, without chronic conditions has a major surgery. It's kind of a bit of a funny example because if they don't have chronic conditions and they're healthy and fit, they might not be having surgery, but we'll go with it. There's a major surgery, and it could be something as simple as a C-section or something. So you're healthy, fit, and they have a major surgery. So that's a noxious insult. The likelihood that that person is going to develop a delirium is pretty low. Now, if you take someone that's highly vulnerable, so someone with moderate to severe dementia, any other kind of severe illness or combination, the multisensory impairment again, vision, hearing, if they've had a previous delirium, or there's things like malnutrition or dehydration, one little noxious insult, like, for example, trying to help with the sleep and introducing a sleeping pill might be all it takes to trigger that delirium. Okay? So when we're interacting with a person with delirium, this is going to be very similar to how all of you already practice, despite what situation you're in. But specific to somebody with delirium, speaking slowly, clearly in a calm voice, of course. And all of you practice this, I know really well, and that's avoiding arguing with the person or confronting the person's errors, even if they don't make any sense. The person, what they're experiencing is very real to them in that moment. What we find is most helpful is just acknowledging the person's emotions, particularly if they're very afraid or fearful. Communicating and helping them understand that you understand that they're afraid. Comfort really goes a long way because the person will be very confused and frightened again, reinforcing that you're there to help them feel safe. And then seeing if there's any way you can ensure that they're, at their best with wearing the hearing aids, the glasses, the things like that, that might be helpful for them. And then any kind of distraction, of course, radio noise, anything like that, to try to decrease some of the confusion and control the environment a little bit if you're in your role and you're there to kind of assess what's going on with the person. Okay, and if you're suspecting delirium, of course. So again, back to the importance of recognized delirium. It's a medical emergency, of course. It can be prevented. It still very, very commonly goes undetected. So prompt recognition, as you know, and treatment, the focus will be on reducing the likelihood of longer term complications for the person. And this could include, of course, prolonged hospitalization, further decline in cognitive and physical functioning. Once a person with dementia, if we can get them assessed and treated and prevent a longer hospitalization, that can go a long way, because we know that once somebody with dementia is hospitalized, there's significantly higher risk of their cognition declining more rapidly and becoming deconditioned, or their physical function will deteriorate more rapidly. And then premature nursing home placement, and of course, imminent delirium can cause death imminently. Okay. So one of the ways we wanted to help you is just talk a little bit about, if you're thinking that this might be what's going on, to offer some suggestions around screening. One of the tools that we want to talk about is something that's really super basic, but it's been validated as being having sensitivity of around 91% of being predictive of a probable delirium. And it's called the single question in delirium screening. So it's essentially one question. It's a question you're asking if you have the option of the collateral person, so the person that knows the person best. Again, we promote that, of course, with someone with dementia, because they're poor historians, of course. So you're trying, if you have that option, you're trying to speak specifically with a caregiver, someone that knows them. And it's a basic question. Do you think whomever has been more confused lately? It's remarkable, the screening tool actually, and what kind of information you can gather by just that one simple question. And again, it can help you understand whether or not the behavior, the priority behavior that's the problem is new, if it's acute, if it's a significant change for the person. By just asking this one question, has so and so been more confused lately? So let's go back to our case study. We're going to come back around to this and see what kind of response we got from George's wife when asked this basic question. Do you think George has been more confused lately? So this is what the wife reported. Yes, he has been more confused now that you mention it. He's been up at night for the past week, which is unusual for him because he usually sleeps really well. And he's more agitated and intent on leaving and going home. But we've lived here for 40 years, so that's not like him at all. So there's the change that you've identified in asking that one basic question to George's wife. So some further screening, again, a tool that you could use as well. It's a simple tool that highlights 7 changes, which may help you identify delirium. But it's also something that we really like, particularly in your role as crisis workers, because sometimes it's challenging to communicate to others, again, what's going on and the reason why you're making the suggestions that you are. So this is a way that you might be able to augment your communication to those that you're working with around what your recommendations are. So I think Sharon's going to pull it up for us. It's called the Delirium Detection Questionnaire. And we're just going to walk through it, how to use it. Okay. So it's very basic again, and you can use it during your interaction with the person. And typically you're going to be asking again the caregiver to help you with understanding what's going on. You can also use it just in your own interaction with the person and based on your own observations in that moment. But ideally, if you had a caregiver or again, person that knows the person, these are the questions you would ask. So the first one focuses on altered level of awareness to the environment in any way different than being normally awake. So again, this could include things like decreased level of consciousness, so kind of in and out of consciousness, difficulty arousing or hyper arousal, and what their responsiveness is like to stimulation in the environment. So if there's a lot of noise and commotion, there's a lot of people there, including you, and the person doesn't seem to be responding to it, probably would score a 3. And then reduced attentiveness, so that inability to focus on you during the interaction. So difficulty concentrating. This is where we suggest you could use a couple ways to measure this. So one would be asking the person, for example, to recite the months of the year backwards, starting with December, and kind of see how far they get. If they're not able to get too far, tells us that there's reduced attentiveness. The other couple ideas are spelling the word world backwards, which is part of the cognitive screening, or serial 7s backwards. So those are a few ideas. Fluctuation in awareness or attentiveness, such as kind of drifting in and out during the interaction or through the day that the person describes as not normal. So the person that you're talking with, the caregiver. Disordered thinking, so the responses, whether it's verbal or action, are really unrelated to the question or the request that you have of the person. And then disorganized behavior, so purposeless, irrational, under-responsive, or over-responsive to requests. So this is where someone either is not responsive at all or they're incoherent, maybe rambling. And then unexplained impairment, impaired eating or drinking, excluding appetite. So the person's unable to perform the actual actions to feed oneself, if that's present. And then unexplained difficulty with mobility or movement. Now, how this questionnaire is scored is It actually has a very high predictive value. So if there's a score of even just 4, the probability that there's a possible delirium is 89%. That's just with a score of 4. And then anything 9 or above, it's 100% probability that there is an existing delirium and immediate medical evaluation is required. This is where we find this one really helpful, again, particularly communicating to in your role within a crisis worker, the reason why you're recommending, for example, a trip to emerge to be evaluated, because you feel like there could be a delirium and you know that immediate medical intervention is required. Okay, so we're going to go back to our case study and just see what happens when the detection questionnaire is asked of George's wife. So we found that George scored 3 on the question 1. He's very agitated. He said difficulty concentrating. He couldn't get past October for the months of the year backwards, so he was scored a 4. She says he was a bit clearer this morning, but he's been worse since lunch. So there's that fluctuation. He's now rambling in his sentences. He's incoherent. That's based on your interaction with him and your observations. He's muttering, he's pacing around, so he's very purposeless behavior. But she said he is still drinking using a cup, and he seems to be walking okay. He seems to be pacing without impairment. So George is scoring a 15. So definitely above a 9, and the probability of delirium with George is very high. So what was the outcome in this particular case? And we've taken these cases from cases that we've reviewed. So generally speaking, this is something that's possible. So in case, the case study outcome was the crisis worker felt confident that a delirium was present. With the completion of the tool, it helped to inform and support the recommendation that the client needed to be assessed in the emergency department, medically assessed. They were able to use it as a basis of communication with the police, healthcare team, including the family doctor, and with family. And it supported the required documentation that I know all of you are required to do within your role. So that was the outcome of the case study with a specific focus on delirium. Any questions so far? I'm going to pass the torch here to Sharon to continue with the rest of the presentation. And then hopefully at the end, we have room for questions or any kind of comments. So I'll just get Sharon to carry on, unless there's any current questions. I haven't looked at the chat lately.
I would agree, Terry. I think we have some time. So if anybody does have any questions about what Terry's reviewed already, please just go ahead, either chat or verbal, put up your hand or ask.
Anyone reflecting back now and thinking,
Was that helpful in understanding you're talking a bit more about delirium? Okay, let's hope. Okay. Okay, so and I did send to Carmen. Thanks, Lauren. I did send to Carmen the 3 resources that we are referencing. And so she tried to attach them in the chat and wasn't successful either. And so she's going to email it out to participants. So you will have it. And again, it's a copy of the tip sheet, which is really just this general presentation in summary on 2 pages. So you'll have something to follow, hopefully that's easy. And then the delirium detection questionnaire, which Terry just referenced. And then also we're going to be talking about the mini cog. And so that's the 3rd one that we have referenced and attached. So I'm just going to, please email Carmen. That's great. If people would like the attachments, and then she'll have a record of your email and then she'll be able to send it out to you. That's a great idea. Okay. So I'm just going to carry on again and focus on, we're still working through the physical, the P of pieces, and why we might see people with behaviors and how we need to think about what might be contributing to the behaviors. As Terry mentioned, you're not doing a complete assessment, but you do want to kind of keep in the back of your mind, or at least ask the person, if you do have collateral, person to talk to. Because disease, any changes in disease might definitely be contributing to change in their behavior. So have there been any recent medical visits, any recent visits to the doctor, the hospitalizations, right? You could find out that, he's just been seen by the doctor yesterday, and that might be what's contributing to this change in behavior. Because things like heart problems, lung problems, like infections, as Terry mentioned, blood sugars, their sugars could go really high or really low. Cancer, other medical diagnoses, of course, can contribute to changes in behavior for all of us. And for the elderly person who's more vulnerable, we can see those changes can lead to behavior a little bit easier. The next D, so as Terry mentioned, PIECES breaks down the physical into the 5 Ds. So delirium was the first disease we've talked about. The next D is drugs. What medications are being used? Any recent changes to medications? Are all the medications being taken as prescribed, or are they not taking some? Or are they taking too many over-the-counter, over-the-fence medications? Because again, a person who's older, a person with a vulnerable brain, if they have a dementia already, are at higher risk of reacting with all these medications. And it is rare these days to have an older person, maybe over 70 or 80, with no medications. And so you do get this mix. And again, that can contribute significantly to behavior.
Another I'll just add there, Sharon,
sure.
with when you're in that position, often the older adult will have medication in various locations within the home. So there might be some that are visible there on the kitchen table, but there might be some inside, the cabinet in the bed. Like they could be almost anywhere. So or mixed in a old medication container with the originals somewhere else. So just keep that in mind when you're looking around and observing the environment.
Discomfort, pain, a significant contributor to behavior, again, if somebody is in pain. But even if they're hungry, they're thirsty, they're constipated, they have urinary retention, they've got lack of sleep, all of those things can contribute to a change in a person's behavior. A lot of those things can contribute to a delirium, right? And what we're seeing in person. So again, just to ask if you've got the opportunity to ask somebody, is there any pain or discomfort or medications related to that? And then disability, sensory impairment, significant. We often forget that with the older person, but if an older person, especially an older person with a cognitive impairment, an older person with the dementia, if they don't have their sensations maximized, if they don't have their hearing aids in, their vision, their glasses on, it puts them at a higher risk of a delirium just by that basic fact. And so the more you can make sure that they're being used when you're doing your assessment, when you're involved, the better. So that's the P in a real quick nutshell, physical reasons for behavior. And I should mention too, that this PIECES framework that we're talking about is actually a 2-day program. It's a 2-day course if anybody's interested. I've got a reference at the very end, but if anybody's interested in taking PIECES as a information tool, to gain information about delirium or dementia responsive behaviors to help you understand and manage, the link is at the end. We'll talk about. So the physical is the P, and the next I'm going to talk about is the I, the intellectual reasons for changes in behavior. And really we focus on that, on the dementia, the cognitive losses. And so what I'm going to do is talk just briefly about dementia, again, what it is and how to screen for it really, really briefly. But dementia is that gradual progressive decline. So Terry talked about delirium being acute change. It's a change hours to days, and it's a change in very acutely. Dementia is changes in months to years, gradual progressive decline in memory, in mental processing ability that affects memory, normal thinking, communication, language, judgment, reasoning. So it affects all parts of the brain eventually. I have some brain pictures that'll help us see that, but all of these symptoms make it difficult to perform even daily simple tasks, right? It affects all of our functioning. And so as Terry mentioned earlier, there's many different causes, and we've got like 90 different types of dementias right now are recognized. But the 4 on the left of the screen under the umbrella are the 4 most common ones that we see. Alzheimer's disease is still the most common type of dementia. I think they still say 40 to 50% of dementias are Alzheimer's type, but quickly followed by Lewy body disease, which is kind of half, I think of it as half Alzheimer's, half Parkinson's. You've got frontal temporal lobe dementias, which are more initially focused in the front part of our brain. Pick's disease is an older diagnosis that used to fall under that category, frontal temporal dementias, and then vascular dementias. So if you've got little TIAs, transient ischemic attacks, or damage to the parts of the brain because of little strokes, mini strokes, vascular dementias are kind of the up and coming dementia because of all the insults to our cardiovascular system. People are having more problems with their cardiovascular system, just as it affects risk of heart, just as it affects risk of stroke, it also affects risk of getting a dementia, a vascular dementia. But in addition to those 4, there's many other types of dementia as well. Because Alzheimer's is the most common, we do talk about Alzheimer's the most, and so the prevalence doubles every 5 years after age 60. The typical pattern is early memory loss and then gradual functional impairment, but the end result is always a brain atrophy. So the brain actually shrinks, cells wither and die, and abilities are lost. And what we know is by the end of the disease process, 2/3 of the brain function have been lost. So that's an awful lot. So 2/3 of the size of the brain, not only on the outside, but all inside too. So 2/3 has been lost. And so I always think the person is trying to do the best they can do with the brain and the abilities they have left because of the damage. So these are some SPECT scans. The normal brain is nice and clear and rounded and no holes. And then the brain of a person probably with early to moderate Alzheimer's disease. And again, the holes just show the dead cells and the parts of the brain that have died because of the damage. Because of why, they still don't know why with Alzheimer's, but the end result is a very damaged brain. And so it helps again, we need to understand this so that we can understand why a person behaves and acts the way that they do. And as a result of all those brain damages, Alzheimer's disease, of course, changes a person's emotions and their mood and their behavior, their physical, cognitive, and functional abilities. Every part of a person changes because of the disease. And how we try and understand the changes that we see are really talking about the losses of dementia. Now, this is really very general and very kind of, it's kind of old school. We've been doing it for a long time. I still think there's parts of it that are helpful. So that's why we still talk about generally losses of dementia include 7 in 7 different categories. So loss of memory is amnesia, loss of language is aphasia, loss of recognition is agnosia, loss of purposeful movement, praxia, loss of self-awareness and insight is that anosognosia, then there's altered perception and apathy. And we'll talk about each one of these as we go, because again, we think that because you're probably interacting with people with dementia at any one time who might be having behaviors, the more we understand about why those behaviors could be happening, the easier it helps us not only come up with care plans, what next steps to do, but it helps us problem solve and put better things in place. So loss of memory, amnesia. Amnesia is kind of the first thing people think about. It's classic symptoms of dementia, especially with an Alzheimer's disease. And there are 2 main features of amnesia in dementia: difficulty learning new information and then difficulty remembering past events. So there's a picture again of the hippocampal area. So a normal brain on the top and one that's been damaged with Alzheimer's on the bottom. So there's no question as to why learning new information is difficult, as well as remembering past events. But a way to think about what does that actually look like is a very simple analogy, but we were taught this years ago, and every time we talk about it with care professionals, it resonates with them. So we keep on doing it. So if you think about when you were 3 or 4 years old, that's probably when you are able to remember your first memory. Usually our hippocampus area is formed by the time we're 3 or 4. So think back to when you have your first memory, you are probably about 3 or 4 years old. And we go through life accumulating memories. All right, we're in our 20s, we're in our 30s, 40s, 50s, 60s, 70s, 80s, and we've accumulated memories. The ones, the little stars there, are memories that we might have accumulated that have a strong emotional component. So you think back on your life too, and you think the memories that you've accumulated that have strong emotions attached to it, you're more likely to remember. And you're more likely to be able to recall because there's a strong emotional component. So that's those stars there. And so what happens is you get to 80 years old and you develop a diagnosis of dementia, of Alzheimer's disease. So what happens is as Alzheimer's progresses, you lose access to those memories in the reverse order that you obtain them. Okay, so you're 80 years old here, but as the disease progresses, you slowly lose access in reverse order to those memories. So you get to the point where here you're 86 years old, you've had Alzheimer's for 6 years, thereabouts. What you're able to recall, your easy access to memories, only goes to about the age of 40 in this example, okay? So you might, your life experience, you might, it's not like you're remembering back to your 40s, but you actually can't recall anything from your 70s, 60s, or 50s. So that's why you might, people might see behavior in you where you're getting up in the mornings and you say, I've got to go to work, because that's what you did when you were 40. You got up in the mornings and you went to work. As the disease progresses a little bit more, so say somebody's had the diagnosis for 10 years, they're now actually 90 years old, but the outcome is that it's not easy for them to access all these memories of when they were in their 40s, 30s, and 20s. So they might be at 90 years old, and we see this every day in long-term care where a person believes that they are looking for their mom. I'm looking for my mom. I'm looking for my dad. Where's my mom, right? I'm looking in the mirror. So if you've got somebody who might be 90, they look in the mirror, but because they don't have access, they can't recall those other memories of when they were 60s, 50s, 40s, they look in the mirror and they don't recognize the person in the mirror. They believe they're maybe 10 or 12. They're looking for their mom. They're looking to go to school today, but they don't recognize themselves in the mirror. People who also have English as a second language, right? They've learned English maybe when they're in their 20s or 30s. They lose access to English as well. So they revert back to their first language because the learning of English is in the areas of time that they've lost access to. So hopefully that helps, again, people understand why their ability to recall has changed significantly. And it's not, again, like they're remembering back to when they're 10 years old. They truly don't remember the intervening 60 or 70 years. And that's why in our example too, we've often had a person wanting to go home, right? So I need to go home. And so family have taken them home, but the home that a person might be looking for is the home, their childhood home from when they were 10 or when they were 20, not that the home that they've lived in for the last 40 years. Anything to add to that, Terry? I hope that makes sense. Okay. And if you have any questions, don't hesitate to ask. You send us a little thing, but hopefully that makes sense. So that's amnesia. Loss of language is aphasia. So again, we need to understand that the parts of the brain that are damaged, all parts of the brain are damaged, but they also result in losses in ability to express language and to understand, but they're not lost in unison. So somebody could still express themselves fairly well, but not understand what people are saying to them. We've had people in the early stage of dementia say, I know, I hear what you're saying, but I don't understand. It's like you're talking a different language. It's the processing and the understanding of the words that are changed. So they can't always interpret words. As a result, can't make needs known, can't find the right words. You might have somebody with word salad, They're just using a whole bunch of words, but it doesn't quite make sense. And again, that's because when you look at the pictures on the left, right, there's quite a lot of damage to the part of the brain that helps us with language. What is preserved, though, is understanding nonverbal language. So we often talk about the importance of having people recognize or understand the importance of their nonverbal language, and don't rely as much on words and don't rely as much on talking to the person, but making sure your nonverbal is comforting, is reassuring, is calm, because your facial expression, your tone of voice can go a long way. I think that's it for aphasia, loss of language. Loss of recognition is another loss, so we call that agnosia. So person's not able to recognize objects or faces. So we'll have, again, a person who's, again, more advanced, maybe in a retirement home or long-term care home, who doesn't recognize what to do with their fork, right? So they'll utensil to use, might pick up their hairbrush and start to try and brush their teeth. They know they have to do something with it, but recognizing the use of it is changed. Recognizing faces as well, right? So if you think back to that initial, so sometimes again, as a person, dementia progresses, they lose their ability to recognize their family members. They don't recognize their son. They don't recognize their grandchildren. So it could be agnosia because of loss of recognition, or it also could be just memory. I don't remember my son. I don't remember I have a son. And so it's very hard for families, and we do really encourage families to connect with the Alzheimer's Society, especially with a new diagnosis, because there's a lot of information about how to understand the dementia and what we're seeing. But loss of recognition occurs across all sensory modalities as well. So not only just what they see, but also sounds, what they hear, smell, taste. We had a lady who was living at home and didn't recognize the sound of the smoke detector, and so was in the home with all the smoke because the pots were burning. And their daughter called and she said, "Mom, what's that sound?" And the mom said, "Well, I think I hear crickets," right? But it was actually the smoke detector. And so again, results in a lot of safety issue because of that loss of recognition. Loss of purposeful movement. Won't say a lot about that, except it's that there's a disconnect. There can be a disconnect between what the brain is telling the body to do. And so difficulty might be initiating purposeful motions or actions, intentionally going to pick up that water. They might be automatically being able to pick up the glass of water, but intentionally might have trouble doing it. Unable to sequence steps of a task, right? Loose sense of right, left, up, down, front, back. That's why some people, again, in the later stages of dementia, might get dressed and might have their underwear on outside and their sweaters on close to their skin. They know that there is an order, but the order and the sequencing is mixed up, and that's apraxia. 5 is loss of self-awareness or insight. We call it anosognosia, and it's when the front part of the brain is damaged. So there's no illness knowledge. So they don't know that they don't know, and they forget that they forget, which is really, really difficult, again, for family members and for people who are trying to help them. Because when this part of the disease happens, or when this part of the brain is damaged and a person has this lack of insight or self-awareness, there's no sense in trying to say to them, "I'm here to help you," right? Well, they'll say, "Well, I don't need any help. I'm here to help you with your bath." "Well, I don't need help with my bath. I just did it this morning," even though it might have been months since they'd actually given themselves baths or done personal care. But they don't remember, and they know that they would do it if, they know that they've done it. They have no ability to have that insight or that self-awareness. And so often, if this is present, we really encourage people just to kind of go with the flow, agree with them. "No, I'm sure you did your bath this morning, right? But let me just check your back," right? How can we work around their lack of insight or their loss of self-awareness so that we can get our job done if we're there to help them, but not attack their firm beliefs that they are just fine and that we're the ones with the problem? Okay. 6 is altered perception. It's something that we're learning more about, is actually what they're perceiving. So there's a lot of changes to visual perception and changes to what the person with dementia sees as the dementia progresses. So definitely depth perception is changed. They lose the ability to see in 3D and it becomes more like 2D. So they lose peripheral vision quite early in the disease process, actually. And as the disease process progresses, they lose more and more peripheral vision or what they're able to concentrate on. And so as a result, they might have misperceptions. They might see, you know, garbage bag down the hall and it becomes a black dog, or the bathtub might become a deep pool of water. Changes in flooring, right? So you've got somebody who might have difficulty crossing from a shiny floor onto a carpet because it's a depth perception change. So the visual changes are significant and can lead to their behavior, can lead to changes in a person's behavior. So again, the more we can try and understand what they perceive and what they're seeing, then the easier it is for us to work with them and understand their behavior. And then the last is apathy. So that's it's common with dementia. Loss of drive to initiate activities. It's not the same as depression, but it's just apathetic. I'm not able to get up, lacking motivation, unable to initiate speech, so quite content just to sit all day, very unconcerned. People with apathy sometimes are more difficult to recognize because they don't usually cause problems or cause any behaviors, and they're kind of easy, but how can we help the person who's apathetic and maximize their quality of life rather than just letting them be apathetic there? So that's really, in a nutshell, a way of trying to understand quickly dementia, whether and the effects of a dementia and the effects on behavior. The Mini-Cog is a 3-minute screening tool that can increase detection of cognitive impairment in older adults. So you might be called into situations where you're wondering, you know, does this person have any cognitive impairment? You might not know. And so it can be used, it's kind of a simpler one that can be used to help you determine, is this something that might be going on? You're not screening, you're not making a diagnosis, but you're just kind of recognizing, you're helping recognize. Let's see where that is. Yeah. 1 second. You're recognizing is a dementia could be present. I'm just trying to find it. 1 second here. There we go. Okay. So this is what it looks like. It's 3 questions, and it's the Mini-Cog, 3-word registration. So the directions are here. You ask a person to remember. You choose version 1, 2, whatever version we'd like. You ask the person to remember these 3 words: banana, sunrise, and chair. You say them now. You ask them to repeat. Then you do the clock drawing, and the clock drawing is being deemed to be very specific and very successful in helping you recognize, may there be a cognitive impairment involved here? And so the clock drawing is, I want you to draw a clock, put the numbers where they go, and then say set of hands to 10 past 11. So on page 2 is a picture of the circle that you would use. And so you just have them do, and your assessment is the clock normal or not? And then the 3-word recall. So then you ask them to recall those 3 words from step 1. And so then you'd score them, word recall, the clock drawing, and the total score. And then determine whether, you know, that there might be some cognitive impairment here versus, nope, this person is probably cognitively well. Again, I'm not sure of situations where you might feel that would be helpful, but we wanted just to offer it to you as a simple thing that might be helpful. You're not doing screening, as I said, but it might be helpful. Okay. So that's it with respect to the eye. So we've done the P, the physical, we've done the I, the intellectual. Now we're going to go through emotional. And emotional is looking at what kind of emotional reasons could a person be having these behaviors. It could be a depression, a mood disorder, grief, loss, psychosis, hallucinations, delusions. We're not going to go into great detail other than highlight depression because it is the most common psychiatric disorder in later life, often associated with physical illness and not uncommon, right? So we highlight SIGI CAPS, and again, you're probably all familiar with SIGI CAPS as an easy way to screen whether what you're seeing could be related to a depression. So you're going to explore, ask about sleep, whether they've got interest, feelings of guilt or regret. This version that we have here includes the colon and somatic complaints, because what we often see and what some geriatric psychiatrists often see is an older person who is depressed might have a lot of somatic complaints about bowels, headaches, GI system, stomach problems. So that's where the colon comes in and the GI. Energy might be lower than normal, poor concentration, memory, appetite's affected, psychomotor retardation or agitation, and then a suicide ideation, passive wish to die. So SIGI CAPS is just a way to help again us consider whether depression might be part of the puzzle in what we're seeing in terms of the behavior. What we have to remember that a lot of us are very familiar with depression, of course, but sometimes in the elderly person, it can present atypically. And so what we do see in an older person might be less focused on the mood. Often they'll deny that they feel depressed. No, I'm not depressed, I'm just fine. So depressed mood may be less prominent and they'll often deny that. But what they might experience and people might see is more of the anxiety, the irritability. Importuning is not uncommon, and importuning is kind of that, it's been described as whining, kind of the whining personality. Somatic physical complaints are common, as I mentioned, and even cognitive impairment. So pseudo-dementia, cognitive impairment can definitely be involved if there's a depression, and yet if it's not teased out, is this a depression or is this a dementia? It can be mixed. So cognitive impairment is more common in the elderly because of depression, and psychosis is more common. And so because psychosis is more common in the elderly, especially that with a depression, we wanted to highlight psychosis. And you might be, when you're called out, interacting with people who are psychotic, having delusions or hallucinations. So psychosis is that debilitating mental condition, losing contact with reality. It alters how a person thinks, includes delusions or that fixed false beliefs and hallucinations. What is helpful though is when we've taught this before, sometimes it's not easy to help the team, help the family, determine how bad are these delusions or these hallucinations? How bad is this psychosis? When do we need to act on the psychosis? And so the 7Ds is a tool that Pieces promotes. And again, it's going to be in your tip sheet that you'll email Carmen about, and she'll send it to you. But the 7Ds is that, and it's a way to monitor psychosis. But it's an effective tool to help assess whether behavioral expression related to the person's psychosis requires urgent or immediate intervention. So it's a way to communicate and determine as to what we're seeing, something that we need to act on fairly quickly, or is it something we can kind of wait on? So it's just a way of thinking about the psychosis, how the person presents either their hallucinations or delusions, and to consider whether these are dangerous, whether these thoughts, these beliefs, these actions are dangerous to self or others, distressing, disturbing, whether they're jeopardizing independence. So are they not going out of the house because of their beliefs that, the bugs are there, or whatever their delusions or the hallucinations are. Are they jeopardizing independence? Are they taking direct action in response to their delusions or their psychosis? Is the psychosis distant versus is it present? And is it definite? Right. Is it fixed versus they have some insight that there might be, this might be a psychosis. So the 7 Ds is a way, and we teach this in long-term care an awful lot, is a way to document so that we can monitor over time. And I'm not sure, again, whether this would be helpful to you, because I don't know if you're back in again, but it's a method of communication to other team members and to other people as to what you're seeing and how you would assess the risk related to these delusions and whether they require urgent or immediate intervention. Okay. So the last thing we wanted to talk about, oh no, not the last, but the last of the emotion is just highlighting suicide behavior for the older adult. Because we know when we were talking with the impact group, the crisis workers who work in Waterloo Wellington, that they use the safety protocol. And I'm sure that a lot of the other teams across the province use a similar sort of protocol, talking about identifying the risk factors, for example, the resiliency factors, and kind of coming up with that determining levels of risk. We wanted just to highlight or add in there that in addition to what information is already on the safety protocol with the CSSRS, there are some additional protective factors really specific to the older adult, just to highlight that for the older person, there's great resources, and I think I've put them at the end. No, I haven't, but there's really great resources from the Canadian Coalition for Seniors Mental Health, which talks about suicide assessment and suicide in the elderly. And so they've identified, you know what, that if a person, an older person, also has a sense of purpose, meaningful life, hope, and an optimism for the future, engaged in activities, they've displayed good health-seeking behavior, they have financial stability, and a history of seeking help to cope with one's life challenges, that can be helpful information to you in determining what might protective factors be. So it helps us screen for the resiliency of an older person. And it's different from a person who might not be on the older side, right? So we just wanted to throw that in for you because, and then highlight this really good resource. Actually, I'm going to pull this up now too, if I can, while I'm talking about that, because it's another good resource about screening for, there it is. It's from the Canadian Coalition for Seniors Mental Health, as I mentioned, assessment and prevention for older adults, and it's based on national guidelines. So again, it might be helpful because it talks about the assessment process, key questions specifically for the older adults, risk management strategies, which might be very similar to what you already do, of course, in ongoing risk management. But risk factors and resiliency factors are a little bit different for the older person. And it highlights the warning signs being, is the path warm or ski caps? And then highlights the resources. And so this is a pocket guide, I think they call it, specifically for, as I said, the older adults, not older adults with dementia. So that's another complicating thing if you've got an older adult with dementia who might be suicidal. There's other things to consider, right? Like, can they actually follow through or come up with a plan and implement the plan if they've got a dementia or cognitive impairment? This just focuses on suicide prevention for the older adult. Okay, so the last parts of what we want to talk about is just kind of pulling it all together with the C and the E and the S of pieces. So we've highlighted the P, the physical, the intellectual, and the emotional. The C and the E and the S, the capabilities, is trying to, again, you're very limited in your ability when you're interacting in a crisis situation, of course, but the more information you can find from a person, from a collateral family member about their capabilities, how they're affected by the environment and or social. This information can help us understand who the person is, how they may behave, and helps us develop a more effective and individualized care plan. So again, if you're in the moment with the person and you're talking to the family member and they mention about something that might help us explain their behavior, the person's behavior, that's where it might fit into. So PIECES is just a framework to help us kind of check some boxes and how can we understand who this person is and what might be contributing to the behavior, the priority behavior of concern that we're seeing. And then that takes us to question 3, the planning and next steps. So hopefully by having a more comprehensive overview of what might be contributing to somebody's behavior, it'll help you feel like you've got some more information to connect with the primary care provider, whether it's the physician or the nurse practitioner, home and community care, specialized geriatric services, or Behavior Supports Ontario. Again, those services and programs differ across the province, and so you know what's available in your part of the province for sure. Geri MedRisk is a program, a provincial program that's available to everybody, and there'll be a lot of other things that would be helpful to you in your specific situation. But question 3 is where you would just kind of pull it all together and say, okay, what do I need to do based on the information that we've gathered previously? So I'm going to go way back to a summary of that tip sheet because, oh, it's way back. So we wanted just to again, oh, no. This is the tip sheet in summary. So the PIECES framework, what's the priority behavior of concern? How can you help the team? How can you, when you're involved, describe the behavior using objective words and help identify what's changed? How is this behavior that you're seeing today different from last week or from 2 weeks ago or a month ago? Question 2 is, have the risks and the possible contributing factors been considered to what might be contributing to the behavior? And then question 3 is next steps, further investigations, communication strategies, or any specific care strategies. So that's it for us. I'm hoping you guys are free to ask any questions right now, or I've got our contact information at the very end as we get to the end. Terry and myself. Terry's with CMHA in Waterloo, Wellington. I'm with Home and Community Care as our host organizations. But you're free to connect with us, or as I mentioned, email to Carmen about getting those resources, and she can send them out to you. But any questions or any thoughts or comments? Was that at all helpful?
Could I ask a question about something that I saw in the news last night or this morning? Apparently, there's a new wonder drug that's being marketed for Alzheimer's. Are we aware of that in Canada? Is that something in the US only? They're saying they're supposed to be getting phenomenal results with it.
I just saw that myself this morning as well, so I'm not sure. I haven't heard it before. I'm thinking if anybody, the Alzheimer's Society might be more familiar with it, but it's promising, isn't it? It would be very, very nice. We've had years of no hope, so it would be wonderful if there was some hope. Yeah. Thanks for bringing that up. Yeah. And Catherine?
Yeah, hi, thank you for that. That was really, I learned a lot from your talk.
Good, good.
I was wondering, how do pre-existing mental health issues and intellectual disabilities, do they increase the risk of dementia delirium? Is there like an effect on that we know about?
Definitely. Do you want to answer, Terry?
Yeah, that's a great question.
Yeah.
I think I don't know what the statistics are, for all developmental diagnoses, but we know specifically with Down syndrome, because in the last many years, adults with Down syndrome have been aging more successfully, healthier, so been living longer. And I think it is typically aged 35 and after, each year after, the incidence of also developing Alzheimer's disease is like 5 to 10% increase each year after the age of 35. So if anyone with Down syndrome lives into their mid 40s, they will definitely also develop Alzheimer's disease.
I always think of the vulnerable brain, right? When
Yes.
you've got a vulnerable brain, a person with schizophrenia, for
Yes.
example, has a much higher risk of developing dementia as they age.
And that could also be from treatments,
Yes,
right? So it
yes.
makes your brain even that much more vulnerable
Yeah.
because of the medication you've been taking for many, many years.
Mm.
We know that if there's a new diagnosis of mood disorder or depression in the older adult, that where there hasn't been any history in mid 60s, early 70s, often it's a precursor to the beginning stages of some type of primary progressive neurocognitive disorder like Alzheimer's disease. So like Sharon said, it's the vulnerability of the brain. Any kind of insult, brain injury, so say car
Yeah.
accident with brain injury, that's if the light switch was going to go off at some point, it's likely it will go off a lot earlier given the damage to the brain. Alcohol use, of course, misuse, I should say. So higher, not even necessarily higher amounts, but just misuse dependent on the particular person. Higher risk for developing dementia, specifically Wernicke's or Korsakoff's, which is alcohol-related dementia. The only risk factor that we don't have a whole lot of control over, which is one of the risk factors of developing a dementia, is age. Lifestyle plays a huge role. And then again, of course, previous damage to the brain, which will include some of those major mental health diagnoses, as well as any kind of developmental diagnosis or brain injury. Any other questions? Comments? We always welcome feedback. Just want to thank all of you for participating. We do hope that you're able to take some of the information away and apply it to your own role. And as Sharon said, if you took note of our contact information, we're always open for any questions or conversation. Just shoot us a message and we'll be happy to connect. Any other comments, Carmen, or questions from you?
No, except to say thank you. That was absolutely wonderful, really informative. And we really appreciate you giving of your time so freely. If people, I put my email address in the chat box in case anyone missed it. It's carmen@waterloobaleprogram.ca. If you want to email me, I'm happy to send the slides as well as the handouts, the tip sheets that Sharon and Terry were referencing. So don't hesitate to reach out, and we're hopeful to post everything on the CWSO website in the next couple of weeks. So thank you again to Sharon and Terry. That was wonderful, and I think you're probably going to drum up more business for yourselves as we're working with an aging population and encountering some new challenges that we're probably not as trained to do as you folks are. So thank you again.
Thanks
Wonderful.
for the
Thanks for having
opportunity.
us.
Yeah. Take care. Okay.
Take
Bye-bye.
care,
Great.
everyone.
Have a wonderful day.
You
Thank
too.
you.
Bye-bye.
Bye-bye.
Thanks.